Welcome everyone to our event where we'll discuss innovation in health tech and how it can help to overcome some of our current barriers in order to deliver high quality, safe and equitable healthcare. My name is Ana Luisa Neves. I'm Associate Director and Research Fellow at the Patient Safety Translational Research Center at the Institute of Global Health Innovation here at Imperial. And our work focuses mostly on how to accelerate the adoption of digital innovation for patient safety into practice. We work around several areas of research or themes that span across the breadth of patient care, from improving diagnostics to making medication safer, and also trying to understand which are patients' needs in these areas. So we address patient safety at both patient level and also at the systems level, trying to understand how patients can actually embrace digital innovation and use it for patient benefits. Today, we are joined by alumni, students, and friends from 33 countries. We are very pleased to have you here. And for the next hour and so, we will hear from three of our alumni at Imperial that are doing digital innovation, running their own startups and overcoming these barriers to implement health innovation for patient benefits. As technology tries and effectively changes healthcare delivery, we want to hear from them and impact of these digital tools improving patient care, which are the changes that actually happened to date, and which are the changes that we can expect to see in the future as well. We are very pleased and very fortunate to have today Professor Alice Gast with us, who's the president of Imperial. We are delighted that she agreed to share a few words before the start of this event. So thank you, Alice, for joining us today. I'll pass it over to you now.
Well, thank you very much, Anna. And it's my absolute pleasure to welcome so many of you from all around the world today. Our alumni, students, and friends are very important to us. You are our best ambassadors, and you're our advocates for what we do, and you're great benefactors. And I want to thank you for all that you do. I'd also like to start by thanking Nicola and the great alumni office team that she has built, because they're putting on these fascinating events, drawing our alumni and our staff and our students together in ways that help us enlighten the community and bring really new insights into the discussion. And so I want to thank in particular Karine for putting together this event. And as always, our technical support team who've been incredibly important to us. We couldn't have a better panel today than with Abdullah, Saira, Arjun, and Anna. And it's an exciting breadth of experiences and insights in healthcare. And of course, I can't begin to capture all that is in our minds these days. As we begin our recovery from the global pandemic, we learn to live with a new virus and new precautions in our lives. And we think about health and healthcare and safety in different ways than we did before. Of course, throughout the pandemic, our research activity has been profound. We had a wonderful public health groundbreaking for our new School of Public Health in White City. And that's a really important opportunity for us to bring together our world-leading School of Public Health and engage them not only worldwide, but also with our local community in White City. You'll be aware of the groundbreaking and world-leading work in pandemic modeling that has come out of Imperial College London. But in addition, we've developed new detection capabilities and means of testing, new vaccine technologies, new therapies, and even human challenge studies that have been really important. Our Institute for Global Health Innovation and the School of Public Health and others pulled together to do the most comprehensive study in the world, the REACT study. Just Tuesday evening in another discussion, we heard how the REACT is carrying on to study long COVID. And I will put a post in the chat for you all. There's a wonderful story on our website where you can meet the scientists behind the REACT study. The REACT study has tested more than 2.5 million people across the country. It is the most comprehensive study in the world. And it was wonderfully co-sponsored and pushed forward by Lord Darcy, our IGHI co-director. But in addition to the research, it's been a profound time for education. We've not only been developing new modes of education for our own students, but we've been thinking very hard about how to educate the broader community and thinking about how to inform the public when news and insights into a new disease and a pandemic were so important. We've had wonderful online courses through Coursera and edX that have really helped us reach a much broader audience. But we've also done incredible innovations on campus. And I'll give you another link to a wonderful thing that you can read showing the pandemic, how the pandemic has led us to innovations in teaching, using technology and also combining hands-on laboratories in a box that we can ship to people with online education. The last thing I'd like to point out is that our people are so important to us. And as we're coming back on campus and being together, we're really recognizing that critical importance of the interplay between our research and our teaching and the opportunities we provide for students going forward. I'm really proud to say that we've just announced a very bold investment in scholarships, international student scholarships and scholarships for students who are underrepresented in our community. And I would ask you to spread the word about those opportunities and consider including Imperial in your goals and your philanthropy if you're wanting to support student access to our wonderful education. So I don't want to take up too much time. I just want to say that our alumni are so inspiring and so important to us. And today on our panel, we have two winners of our Emerging Alumni Awards. Our Leader Award, Dr. Abdullah Albeyatti in 2021 and Arjun Panesar in 2020. And we're really proud of them and the achievements of all of our leaders. I'm also really excited that we have such awards programs because we're shedding light on the great accomplishments of our alumni and the things that they do with their Imperial education. So our Alumni Awards are in their third year and nominations are currently open for the 2022 awards. We encourage you to submit a nomination, nominate someone, and we will be excited to reveal our winners in the new year and hopefully have an in-person celebration to congratulate them. So Anna herself is a wonderful leader, and I'm very pleased to hand back to her because I know she'll bring forward a really wonderful conversation with this outstanding panel. So thank you very much for joining us.
Thank you so much, Alice, for joining us and for the introduction. So yes, as Alice said, we have three very inspiring alumni from Imperial that I would invite now to join. And without further delay, I'd like to introduce you to Saira, Abdullah, and Arjun. And I would like to invite them actually to start by sharing a little bit of their introduction about their line of work in healthcare and actually what has inspired you to develop innovation in this area. Would you like to start, Abdullah?
Sure, happy to start. So thank you very much for the very kind welcome and very proud and happy to be here with other Imperial alumni. So my name's Abdullah Albeyatti. So first and foremost, I'm a doctor. I'm a general practitioner, a family physician. I live in Leeds now and I practice serving my community here. I'm also the chair of the Royal College of General Practitioners in the Yorkshire faculty. And I suppose the reason I'm here, aside from those things, is because I run two health tech companies. One is called Medicalchain and the other one is called MyClinic. Medicalchain, we're focused on trying to empower patients to have access to their medical records and change the dynamics we have between doctors and patients. And we've won several awards, including one from the Financial Times. And MyClinic, we started it to really address the problem that we found with COVID. And we launched a telemedicine service, which has been used in over 78 countries around the world. So we're busy working on different things here.
In different fronts. Thanks for sharing, Abdul. Do you want to go after us, Saira, maybe?
Thank you. And thank you very much for the introduction. And thank you to President Gast as well. It's a pleasure to join everyone. And I've had the experience of both being a student at Imperial, but also working at Imperial now as well. My main role is that I lead the digital health team at the Institute of Global Health Innovation, and we do a huge variety of digital activities there, going from cybersecurity to looking at the value of the NHS data asset. I'm also a doctor by background, and I'm a respiratory consultant at St Mary's Hospital. So the last year has definitely been an eye-opener on how to provide care in a digital way. I also run two startups. One is called Psyma, and that focuses on delivering mental health care through video therapy. And the other one is called Prova Health, which focuses on evidence generation for digital health solutions. And look forward to sharing some insights with you.
Thank you for sharing, Saira. Shall we go to Arjun now? Would you like to introduce yourself, Arjun?
Brilliant, thank you, Anna. My name is Arjun. I was a student at Imperial way back in 2002 when I was studying for an undergrad master's in AI, computing and AI. It was actually then that I started my startup or my organization. My grandfather was diagnosed with type 2 diabetes during the winter semester, I think, in my first year. And that was as the result of a quadruple heart bypass, actually. So he had no idea he had type 2 diabetes. And once he was diagnosed, because we're from quite a multicultural family, he had no idea what to eat, because we eat food, we celebrate with food, really. And I said I had no idea, but this really cool website called Facebook had just opened up. So why don't we ask the internet? So we purchased a domain name and we put online what was the world's first digital community for people with diabetes. And fast forward 19 years now, my organization provides services to around about 2 million active members, and we provide digital health interventions, or essentially software as a medical device that empowers people and helps them to achieve improvements in health and outcomes. And really excited to be here today. Thank you.
Thank you so much for sharing, the three of us, and of course, Arjun, for sharing your story as well. I think something that's really inspiring, and you can feel these in your stories, but also in a lot of other stories from innovation, from Imperial alumni, is that quite often these solutions come from personal experiences and from challenges that you have experienced yourself or someone from your family or friends, and that actually allows you to identify a very specific need in healthcare delivery. So I was wondering, based on your experience, but also taking maybe a step back and thinking a little bit broader, which are the current challenges that you think are really key at this moment in what concerns healthcare systems and healthcare delivery? And thinking about the key challenges that need to be addressed, what can you do to make a better job there?
I suppose I can start. I think there's lots of challenges and they're wide ranging. And even when we talk about healthcare, you have to really box what you're talking about. Are we talking about local healthcare, regional, national, international? Are we talking NHS? Are we talking private? Are we talking social care? Are we talking mental health care? I think really a general challenge that looks or interacts with all of these problems is, how do you take patients on this journey with you? And I think that's the biggest challenge that I've noticed. And for all of us here that have delved into health tech and different areas of health tech, it's trying to move the dial along so that when you have all this technology, cameras, smartphones, how are we best utilizing these and getting the most out of them to improve people's healthcare? How are we trying to get patients on a level so that we no longer have this kind of paternalistic approach between a clinician and a patient of, I know everything, you don't, I'm going to tell you what to do, you need to go away and do it. And really to what it's now becoming, where yes, you can Google your symptoms, yes, you can have an idea of what might be wrong, yes, you can have access to your medical records, and we can have a much better dialogue and partnership where you're taking real ownership of your healthcare, and you can refer to websites such as Arjun's and try to have a much more educated and rounded conversation with a clinician for that extra help that you might need in your medical problem. So how do we get that tech to the patients and how do we get them utilizing it, I think is one of the challenges we need to focus on.
I can jump in next, Anna. I think certainly from an academic perspective, some of the stuff that we've been looking at Imperial, but also from a practical kind of patient level, what we've seen over the past year with people using new digital technologies and the proliferation of healthcare data is the trust and security of data, the privacy and security of data. And certainly from some of the research that both Anna and myself have done jointly, shows that actually the biggest concern that patients have with using digital tools and technologies is really the privacy side of things. Are we keeping their data safe? Are we keeping it secure? How are we using that data? And certainly I think most recently everyone's seen in the press the latest kind of news stories about using GP data sets and how that data is going to be used in the future, and how that's actually been halted for a couple of months while it's reviewed again. Again, I think first and foremost, it's that how does the healthcare system demonstrate that it's trustworthy and demonstrate its trustworthiness to patients and the public, but also what reassurances are we giving to patients and the public that we're going to use their data in a safe and responsible way, it's going to be secure, we're going to keep it private, and it'll be utilised in a way that will bring return not only to the NHS but also to UK PLC as a whole as well. It's like, how do we put all of that in the system? And I think that's going to be more and more of a pressing issue as we become more digitally dependent.
That's very interesting, and I suppose it's really interesting because we tend to when we talk about digital innovation and the impact on healthcare systems, quite often the discussion starts from healthcare system perspective, but naturally the discussion goes to the patient role in it and how we actually, as we mentioned before, how to engage patients as part of the process, how can we respectfully use the data and use these tools to actually improve their healthcare. So I think that's I would like also to hear your thoughts, Arjun. Would you like to add something on this one?
Yeah, for sure. I think my perspective might be slightly different, perhaps because I'm not a clinician, but I think from at least my experience, I think it's how we empower those that are typically hard to reach. So digital is obviously an extremely powerful tool to engage a particular type of user. How do we engage those that are, from particular backgrounds, those in deprived areas, etc. And I think that's really key because of the representation required as we collect data and as we, create diagnostic and predictive, systems and solutions on top of this. So although COVID has been fantastic in accelerating this digital transformation, how do we engage those people who don't speak English or require translators or carers? And that's quite a significant proportion of people who require access to healthcare. So I think that, along with sort of how we then connect data, is probably a perspective I've seen from I suppose our a commercial perspective, or how we can get things moving.
So that's really a key point, and thanks for bringing it. I guess one of the things that we keep talking, and this I would say an old concept, but it's something that we've been discussing for some time, is how do we avoid what's called the digital divide? And of course, when we implement, when we think, and design, and trial digital innovation, of course, we always hope that this will improve patient safety, healthcare quality, etc. So there's a genuine goodwill behind it. But we also know that by developing digital technologies, these will work most likely just for a selected group of patients. So in some way, we might be entrenching these existing inequities that are already in place. So I wonder, which are your thoughts about which strategies can we actually implement, and what are the things that we need to do as part of the design of digital solutions to make sure that we are creating solutions, as Arjun mentioned right now, that are suitable for everyone or suitable for the most number of people possible. Do you have any thoughts on this?
I think there's a lot of work being done in this area already. So I really know there's a system now that's being employed by pharmacies. So when the doctor is prescribing a medication to a patient, they can actually put what language that prescription needs to be in. So when that's getting printed out of the pharmacy, the patient can understand it in their language of how they need to take the medication. I think the main point for me is that COVID has shown us it's better to kind of leap and try these things, and most of these things will come through trial and error. And I think definitely with the digital divide, there will always be people that will be left behind. Unfortunately, you can't get everybody. I think it's unrealistic to expect to have 100% of people using a particular digital service. But as time moves on and as generations move on, more and more people are going to be digitally savvy. So I speak as my parents, for example, who are in their 70s, and they didn't know how to use WhatsApp. But when you show them the function of WhatsApp is you can get photos and videos of the grandchildren, now they're experts at WhatsApp and they're leaving voice notes and everything else. Because when you show somebody there's a real function and a real outcome, they will learn how to use it. They'll learn how to interact with it as well. And that will naturally happen. When we're in our 30s or 40s, we'll be the 50 and 60-year-olds. And I think we have to move away from this idea of, yes, we're worried and concerned about the people at one end of the spectrum, but you need to think about the patient who's being born today, the child who's being born today. why are they not getting digitally plugged in? Why are they not starting with, we used to refer to it as a health passport. We don't anymore with the negative connotations of the COVID passports, but why are they not being born with a record there that they can interact with, they can use, that's being digitally added to it. They can take that information to this clinic, that clinic, private, internationally, wherever they want to go. So I think until we try, and then we'll find which members of society have been left behind or need to have telephone appointments or language line and translators, we're going to keep having this debate whilst we're missing out the vast majority that would actually just like to get on and use it. You know, an example is Uber, for example. You could say, well, what about people that won't know how to use Uber and order a taxi? Look about how many millions and millions of people have benefited from such an easy to use service such as that, or other kind of applications as well. So I think we should just get on with it, and we will then find out who's actually being left behind, and then we can address them specifically as a population.
That's a very interesting point. And if I might just add something here, and we have discussed this before, of course, but I was wondering, as you say, if a more agile approach to things eventually can speed up. And I was just reflecting, for instance, as we discussed before about virtual care, in the context of COVID, things were really speed up in a way that we didn't expect them to be. And for instance, in the UK context, there was really a plan to deliver remote care, at least in primary care, by 2019-20. There was an actual plan that was taking place. But of course, when we are just pushed into a situation, as Abdullah was saying, innovation does happen a little bit quicker. And I guess the challenge, and I completely agree with your point, but I guess the challenge is when we try, not the challenge, but eventually the recommendation is that after this trial, how can we better evaluate what happened for which groups of patients, and how can we actually continue learning from these experiences? That's where probably also Saira's expertise in research could be interesting to hear as well here.
Yeah, I'll jump in there. I'm just picking up from what Abdullah was saying. It's making sure that we don't have this in our minds that actually it's all digital or nothing. So it's that whole making sure that we're catering for all needs, and it's that omnichannel approach. So if we look at banking as a sector, you know, you can do it on the phone, you can use your app, you can walk into a branch. You know, that's the whole thing as well, is making sure that you've got the right options for each individual patient, and not kind of saying that you can only use digital, you can only come to the surgery. So it's patient preference, and really we need to be pushing for that. And again, just making sure that we're catering to language difficulties, whether it's sign language, whether it's kind of using language line for, you know, multiple different settings and things. These are all things that not as a last minute thing to make sure, you know, have a family member with you. That's not appropriate kind of thing. It's making sure that we're catering to those patients' needs. But then also picking up from your question, Anna, looking to see what patients in the public really want from a kind of digitally enabled service. I'd mentioned the kind of privacy and security idea before, but also one of the other things that we find from some of the research that we've done is that people sometimes feel that although that it's very convenient to have that digital consultation, sometimes we find groups of people that didn't feel that, you know, or felt that their physical healthcare needs weren't being seen to appropriately, and what they felt was that they would be safer if somebody examined them, or if they were face to face and they felt that they might have missed out. And that could be people who were having consultations by telephone, as we know that slightly older generations, they prefer telephone over video consults, so you don't see them face to face. So it's that reassurance as well as that access and convenience as well to using that digital technology. But lots of different bits to pick up. So, you know, how you use that in practice. Do you have, you know, for somebody with a long-term condition, do you have one appointment that's face-to-face, then the next two that you have digitally in whichever format they want, and have that something that works for them, works for the system, and certainly to make sure that you're providing the best care for them.
That's a very good point. And I think you touched something that's really important, which is about the perception of safety from the patient, but also sometimes from the healthcare provider, because certainly delivering remote care without a physical consultation does increase uncertainty, which is something that we are used to, but not to this extent in a way. So I think I'll just take this chance to just take one of the questions in the chat. is a question from Paul Villarora, and I'll just ask this to you, Saira, because I think it ties very well to what you just said. And Paul is asking, how can this clinical physical examination, knowing that the clinical physical examination is an important component of medical diagnosis, how could digitization bridge this gap in the digital space? How this could be improved?
So really great question there. And I think there's a huge opportunity there, and certainly from a remote monitoring perspective, and this is some of the work that Anna's been leading at Imperial, certainly having diagnostic tools such as a pulse oximeter, a heart rate monitor, a BP cuff at home that links into your digital record, or links in somehow to an app, so you're getting that feedback as well. And I think that would give the patient reassurance as well, certainly as a clinician as well. There's lots of other cues that you pick up on, even I'm a respiratory consultant, so, you can tell how ill somebody is just by listening to their voice, how quickly they're talking, if they are able to complete a sentence in one breath. So little cues like that over years of experience you can pick up on. But actually, if somebody was to stick their finger in a pulse oximeter and it gives you a number that you're comfortable with, then that reassures both the clinician and the patient. And certainly you've got that added safety net. But I think there's a huge role here for all of these different remote monitoring tools. But we need to have them in a way that they actually feed into a record, so they're not just a kind of standalone tool. Because sometimes we don't know if they're, we need to make sure their functionality is right as well. Are they calibrated? But also things like pulse oximeters, we've seen that actually they don't work as well on some minority ethnic patients as well. So, it's considerations like that and making sure that people have got equitable access. But I think things like that, we just really need to bring it in system-wide as opposed to, here's a standalone tool.
Yeah.
I was just going to add, we've done a lot in terms of telemedicine, or trying to promote telemedicine, and it's by all means, it's not a one-size-fits-all for all patients or all consultations. We've even written a book about this called Can You Hear Me?, which is a free ebook anybody can download, which talks about how to deploy and deliver a telemedicine service regardless of the clinical scenario within an hour. And it's relatively straightforward. I think there's a lot more onus from the patient's perspective, thinking that an examination is going to yield the answer. But clinically speaking, what I was taught at Imperial Medical School, and I think it's held true so far, is 80% of the diagnosis is just from the consultation. It's just from the history. And normally when you do the examination, you do the investigation, it's normally to confirm what your diagnosis is. So there's lots of things we do in medicine, or certainly how I'm practicing now in the GP practice. We can do it over the phone. We can do it over the video call. You can send me a photo of your rash. I will tell you, try this cream. If it's not worked within a week, try this cream. If that's not worked, fine. I think it's probably worth you coming in, because either I'm not getting the diagnosis right by doing it remotely, or I'm not getting the treatment right because I'm doing it remotely. And part of, I think, good medical practice, if you really boil it down, is trying to make sure that you don't miss the emergencies, which are not things that can wait 2 weeks. They need to go into accident emergency now. And it's not to miss the very scary things such as cancer, which is, no, you need to be seen in the hospital right now. For most other things, there is some time, especially in primary care, there is some time to try from the history alone, or possibly trying to filter through all those kind of histories, who you need to see physically and who you need to get to the bottom of the query, because you haven't been able to solve it remotely. So it's about perfecting the skill, and it's a new skill all by itself, which I don't think is being taught at medical schools. And it'd be lovely to see Imperial, really take the mantle of this, recognizing that remote consultation and the kind of devices that we're hearing about as well, so that you can check your oxygen or your blood pressure, your pulse. The medical students should be taught this is how you can consult remotely, because it's a different skill set. And I think, just to end on this point as well, there will probably be a case in the UK in the near future where there will be a legal case because somebody came to harm because of remote consultations, and it will come back to, well, were you trained in making this diagnosis remotely? Were you trained to use remote consultation tools? And I think if we can get that right all the way, it should make a big difference going forwards.
Thank you, Abdullah. I might just pick up one of your points in Saira's as well, which goes back to the need to somehow deliver or identify and deliver tailored interventions to patients. And Saira also mentioned very briefly before that all these digital health innovations quite often generate very helpful, very valuable data that could be used to inform this tailoring of these interventions. So I wonder if you'd like to share your thoughts about how could we better use this healthcare data that is captured by, let's say, electronic health records, mobile apps, and other sorts of digital innovation. How can we best use this healthcare data to tailor digital innovation and eventually to bridge this digital divide? I might start by Arjun, maybe. Would you like to share your thoughts on this, Arjun?
Sure. So that's a really good question. I think quite simply, it's personalization. So evidence-based medicine, really the pinnacle of that is precise medicine. How we do that, the way that we do that is through the data that is either shared by the user or clinically input either by the user or their clinician. There are sort of aspects to that then personalize their experience dependent on your health condition or your any allergies or dietary preferences, whatever that may be. But having said that, that is the nature of how we personalize it. Really, what we want to be able to get down to is sort of an ecosystem where the clinical data and the self-reported data is sort of all in the same hub, somewhere where all of the datafication of not just health but life, what people have been eating, how many steps they've been taking, that is really the sort of the EHR that is required, where we're not just looking at sort of what we have clinically, but also what we're generating elsewhere. So that, I think that's how we would achieve it from our point of view. But just to take a couple of steps back, I think that would exclude a significant proportion of the population and a significant proportion of the population that probably need care the most. So whilst I could wholeheartedly agree with everything that Abdullah was saying, we recently just won a bid to provide South London diabetes services, or type 2 diabetes and pre-diabetes services. And as such, we provide customer services to patients that sort of enroll. And for every 100 that come in or book, there's at least 25% of those actually require physical, packs where we engage with them with sort of, physical assets or whatever that may be. And so I wonder whether the digital divide actually depends on where exactly you are in the healthcare landscape. So, for instance, Abdullah, doing or performing, remote care or diagnostics or whatever that is. I know for patients with type 2 diabetes, that's led to sort of greater number of amputations or greater number of sort of foot ulcers, etc. That may be leading into amputation. So there are almost sort of pros and cons for the various, this, where everyone is within this. But I wonder whether, when we do look at the data, we do find those that are digitally excluded are often the most comorbid, because they often have the most difficulty with not just digital, but accessibility full stop, and accessibility not only digitally but physically and perhaps emotionally or else, or in other cases. So it's a really, I think it's a really complex topic where we can provide precise medicine, but then who we leave behind might actually be the people that need it the most. And I wonder whether the democratization of healthcare is such that we can provide a ubiquitous health intervention or whatever that may be, or health ecosystem for people, and then focus on those that are most at risk, because obviously they need people's time, like Sarah's, yourself and Abdullah's time, more than anyone else.
Yeah, I think that's really interesting. I was listening to Arjun, and I think this ties very well with your work, Saira, as well. Saira has been leading a few projects on how to better use healthcare data, and how can they use not only for research purposes but also for public health purposes. Would you like to share your thoughts, Saira, on the opportunities of using healthcare data for personalized and tailored care as well?
Yeah, so certainly just picking up from what Arjun was saying, really interesting about leaving people behind. And one of the reports that we're due to publish is looking at using AI and data-driven technologies for minority ethnic communities. And there was a recent report that was out by the Nuffield Trust, and that really, it was the King's Fund actually, that highlighted the poor approaches to data collection, or certainly coding ethnic-based data from ethnicity-based data even from patients, and how it was so badly coded that actually if you're starting with a very poor pipeline right at the beginning, then actually what AI technology are you going to have at the end? So if you're only collecting it on a certain cohort of patients, very much we're now beginning to use masses of data to create these new AI technologies, but actually if it's only serving one segment of the population, then we're doing a disservice. And, you know, first and foremost, we are, you know, creating a more unequal healthcare system, and that gap is widening for whatever reason. So certainly things like that we need to be very, very wary of as we're moving into this kind of data-driven technology field, and think about how we're collecting data, how we're coding it, making sure that this is part and parcel of everything that we do, creating clean data sets right from the outset. But that's going to take a lot of capital investment from top down.
You make a really, really good point. I think sort of, you know, one of the I'm an advisor to the information school, and one of the things that we often discuss is how we ensure that there's representation, because as you mentioned, your digital, if it does engage a particular segment of society, whether that's, you know, based on, you know, socioeconomics or demography, whatever that may be, there are a group that, you know, may not necessarily be able to engage. And if we fail to gather their data, and if they're already not engaging, they didn't engage in the past. And the concern is that, you know, we know the bias and prejudice that can be exhibited by algorithms. And although you make a fantastic point about, you know, the bias in the data. But I think there's also something to be said about the diversity and the bias in the people that are coding with the data as well. So, you know, it's such a fantastic topic. I could talk about it for hours. But as you can tell, sort of my passion is really making sure that these, you know, that those who require access to these services, you know, get it, but they also get it as they need it. So, you know, for instance, from our background, we know by speaking to people in their language, they engage in it. And Abdullah, you mentioned Written Medicine, which is the company that provides the medication translations. Similarly, we do with our interventions, we provide them in the various languages that people speak. And what we obviously find is, if you engage people in their language, they engage a lot better with your intervention, you know, because it's not in English. And so just a very sort of, you know, key topic, I think, in order to make sure that we don't leave people behind, because we might leave the wrong people behind, and they probably need, you know, the healthcare system the most.
Oh, definitely. And I think making sure that you've got people representing and engaging from, you know, whether it's the academics, whether it's the coders, whether it's the healthcare professionals. And already we see there's so much inequity, I think, in our report, and this was highlighted by The Guardian a couple of years ago, but there was only at one point, quite recently, within the past 3 years, 9 Black female professors in the UK. And that is just, you know, out of 20,000 professors, 9 female Black professors. And we're very lucky to have one at Imperial, but this is absolutely, in this day and age, shocking. And the fact that we don't have more representation, whether it's in academia, whether it's at higher levels in the NHS, across the board, and until we really do something about that, then I think we're doing a disservice to our patients.
And as Arjun said, this is so topical right now, and it's such a key area that we could certainly keep discussing this for a longer time. However, I will still need to make the last question for the three of you. I might start by Abdullah. So we have covered a lot of different aspects, from different types of digital innovation, major barriers, major challenges. We talk a lot about digital divides and the potential of healthcare data. And I was wondering if you'd be happy to share, as a final question, a little bit about your own experience and your entrepreneurial journey, and which were the key lessons that you have learned. Which advice would you give to the students that are listening to this today, and how can they start their own journeys? Which lessons would you like to share?
We haven't got all day. There's so many lessons. I think when I did the piece for Imperial, when I got the Alumni Award, one of the quotes was being a troublemaker. And what I meant by that was challenging the system. And if you're ever given the answer, well, that's the way it's always been, then you know there's something definitely wrong with that part of the system. And my journey really, from a medical student to a foundation year doctor, and then I was training as a surgeon originally in Imperial, and then I moved on to general practice. It's trying to find what those problems are in a system and how you can effectively change them. And I think that the challenge that we have, certainly in healthcare today, is a good solution is not necessarily a good business idea. And I think for the kind of students I have now that I mentor, the very first question I ask them is, why are you doing this? What is your motivation behind this? If your motivation is to make a difference, then I applaud you, and that's a great thing to do. And there's lots of ways of trying to make a difference, and lots of funding and different ways of trying to get support there. If your idea is, I want to get rich, I want to create a business, I want to be an entrepreneur, they don't necessarily overlap 100%, because you could have an idea, for example, I want to give all the nurses on the ward an iPad because I think it's much better for them to record the patient's observations than writing it down on bits of paper. Okay, that's a fantastic idea. So we're going to buy, 500 iPads for the whole hospital. Each one's £500. How's the hospital going to make the money back? It's not. Okay, so how are we going to then, do the cost analysis, cost benefit analysis? So that's for me is the biggest challenge I learned growing up by doing quality improvement projects and audits, that even though you can see a solution on your level, you have to think about it really on the managerial level, where even though it's a very good idea, it doesn't necessarily make business sense. And I think that comes with time, experience, and a bit of maturity. And I think myself, similar to the other panelists here, we're always happy to, having learned from our own mistakes and our own difficulties, try to pass that information to the next generation and say, look, in my experience, this is where I fell down. I was being, too optimistic here, or I was barking up the wrong tree there. And the only advice I'd really give to students is try. Don't be limited, be ambitious, think big. I think one of the things I would probably say to a younger version of me is, it's not a big deal to be a doctor. And I think I didn't get that until I was a lot older. And I would say that the same people doing computing engineering or doing any other degree at Imperial or anywhere else, you are going to do that degree. You are going to pass those exams. That is a given. So stop thinking about that, because that's going to happen anyway, and think about what else you're going to be working on as well. If I want to be a doctor, I had to pass those medical exams. Okay, it's nice for the family. It's a great achievement. Pat yourself on the back. But that's going to happen, and that's the plan anyway. What's the other things you're working on? And I think, Arjun's story really impressed me, because he did this really to help his grandfather. He did this really, regardless of what he was doing at Imperial and regardless of the degree he was aiming for, he thought, well, what else can I do? Because I'm going to end up with this degree anyway. What else am I going to do on top of that? And I think if students start thinking that way, lots of opportunities will start to come your way. And, hopefully you'll be the ones giving this talk next year or the year after that.
Thank you so much, Abdullah. I think it's so interesting, because I think you just touched the two key messages that actually I got from one of these entrepreneurial programs at Imperial. And of course, the first one is around, what is the purpose of your venture? Is it a social venture, or is it something that you need to monetize? And if you need to make profit, the first thing that you need to think is, what's your market? As you very well put. And you touched briefly something that I guess is also very interesting, which is about failure. That's something that we just need to embrace as part of the process. And I always remember one of our mentors saying, this really stood with me. She said, look at failure as part of the process. Failure is like the stepping stone that will improve your product until it gets the best version of yourself. And I think sometimes we just look at failure as something very negative and not as a growing opportunity. And there's potentially an angle there, and certainly an angle that you see when you go through your entrepreneurial journey quite often. So thank you so much for sharing. It was really, really interesting. Saira, would you like to go next?
Yeah, definitely. Just on that point on failure, be prepared for rejection. So having just gone through various funding rounds for one of our startups, it's like really bad speed dating that, rejection over and over again, but that's all part of it. And like Anna said, you improve your product over and over again until you kind of get that pitch right. So I mean, everything is an experience. Embrace it all. Step out of your comfort zone. Ask people, and people around you that you think, oh, actually that sounds really cool, but I have no idea how to do that. Approach people, and what's the worst that can happen is that they'll say no to you. And literally, it's looking at other people. So Abdullah mentioned, it's not that big an achievement being X, Y, or Z. Don't look at other people's journeys. Just kind of think, what do I want to do? Where do I want to be? And actually, part of that is just kind of experiencing new things. I mean, if you asked me 20 years ago, what you'll be doing, I didn't think I'd be doing any of this. I thought, I'd be, actually at that point, I think I was going to study law, but I had no idea what I wanted to do. And, you'll surprise yourself at the new kind of adventures that you have along the way. Embrace it, enjoy it. And if you're not having fun doing it, then it's probably not the right thing.
Thank you so much, Saira. Great advice. Arjun.
Yeah, I think that is fantastic advice. I feel as though my own story, I wanted to be, I would say to everyone, you really have to follow your passion. I actually wanted to be a doctor, believe it or not. And much to my grandfather's dismay, I wasn't able to stand the sight of blood and I fainted on my first day. And so I realized that wasn't for me and thought, how else could I actually make any difference to the world? Maybe I'll do this thing called AI. I completely agree with everything Abdullah and Saira were saying. My own journey really started by accident, and I say this is all completely my granddad's fault. I was interested in biology. I was interested in AI. Thought it was really cool. And what is funny is that what we were being taught 20 years ago is actually what is happening now. So it's the same concepts. It's nothing new. It's just the winter has gone, and now people are able to perform these kinds of actions because we have the data available. My own journey, though, really, I think was serendipitous. I was quite lucky. The mentors that I had really said, if you do something that does good for others, for humanity, whatever that may be, the money will follow. So really, when I started the community, which was the diabetes community, once we got to a particular sort of threshold, people were interested in engaging with it, in speaking to the platform. And then things really blossomed from there. So, as an organization, I feel for Saira's pain about going through funding. We're completely family. It's a family business. And I've been lucky enough to really sort of maintain this as a family business, since we started. And that helps to drive, ethics and goodwill. And I think, it's a fantastic space to be in. And my sort of advice would be, if you feel as though it does good for others, go for it. And if you have a passion for it and you have a talent for it, it's even better. But in fairness, to actually achieve success, you need a constellation of events to take place, and luck is most certainly part of it as well.
Thank you for sharing, Arjun and Saira and Abdullah. Very different, but in a lot of aspects also common experiences, and it was really great to know more about them. I think it's time now for us to open the stage to students. So I'll just go back to the Q&A. We have a few questions actually coming up. They are ranked by the number of people that actually want them to be answered. And the first one is a question for Abdullah. So one of our participants mentions that you made a point, Abdullah, about ensuring that medical students are receiving the right training about remote diagnostics and virtual care, etc., particularly GPs. So the question is whether you think that education is keeping up with this changing landscape of health innovation and incorporating these in curricula.
Yeah, thank you very much for the question, Joe. I think yes and no. So yes, because we're all online here talking about it now, and when we're being given the stage to discuss these things. So I think education is trying to prepare, the future medical students for the world that we're going to anticipate. From my perspective, the two things I've noticed is, one is the kind of health tech side. We need to encourage more and more clinicians, especially our decision maker clinicians, to engage with this. When we talk about patient records, if you are or even if we talk about remote consulting, so if you are the patient and you were to see your doctor fumbling around, dropping their stethoscope, apologizing, I'm sorry, I've got this wrong, you're going to lose faith in that clinician pretty quickly. Imagine doing that online. You can't get the mic working, you can't get the video working. Oh, I'm really sorry, just give me a second, I'll call the receptionist. We have to become a lot more professional in how we do that. And I think the earlier we start, and coming back to what Saira was saying about failing, I think fail fast and learn fast. And the other thing that I think medical schools could do, a bit better, is the kind of entrepreneurial and leadership sides. I know I was in a panel a few years ago where one of the other panelists said, look, I don't think that's the business of the medical school to generate entrepreneurs and leaders in that sense. It's taxpayers' money to produce medics, and that's what they should focus on. But Saira is a consultant in her hospital. She leads a department. She leads a research group. Where was she meant to learn those skills? If you're a GP partner and you're leading a clinic, or you're leading your clinical commissioning group, leadership and entrepreneurial skills shouldn't be frowned upon. It should be encouraged, because that way we won't make costly mistakes as we have done previously, in the NHS, because we didn't have those soft skills. So I think, to answer your question, yes and no, in the sense that it is happening, but it will probably take a few years to filter through, and I welcome the changes that are coming through as well.
Thank you, everyone. Such a important point about leadership skills and thinking a little bit outside of the traditional medical careers. That's a very important point. So we have another question from Jen about something that's very topical. So Jen is asking about the conversation around gathering and using data in a responsible way. And she's wondering if you'd like to share your views on the NHS GP data sharing scheme that has been in the news recently. Shall I maybe ask you, Saira, to start this one?
Yep, very happy to start. So as you know, the latest GP or the latest kind of data sharing suggestion from NHS Digital is to kind of use all GP data across the board and kind of collect data in a much more structured way that can then be used for research purposes, for commercial purposes, or you can work with pharma. So none of this is anything new that's being done. So NHS data sets are being used across the board by different companies, whether it is for research purposes or whether it is for more commercial purposes. This is just happening at a much more whole-scale perspective. I think the big issue with the announcement of this is the communication with patients and the public. So essentially, a couple of years ago, there was a similar program called Care.Data. And again, that kind of fell to its knees because of that lack of communication and public consultation. Since then, as we are generating and using more data in a routine way, and this is across the board, whether it's secondary care data, primary care data, the key thing needs to be is public consultation and taking people along with you. There's been lots of different events that have happened across the country, and certainly there's groups such as Understanding Patient Data. There's One London. There's lots of kind of more localized ones. And certainly there's lots of patient confidentiality groups as well who are taking on this work. And I think when you actually explain to patients and the public how and what this data is being used for, the fact that there are checks and balances in place, there's an independent governance committee overseeing it, certainly everyone who puts an application in for this data and how they have to state how they're going to use it and what the output is going to be, et cetera, et cetera. But I think if you just kind of announce all of a sudden that we're going to scrape, 60 million patient records, and this will go live, and you've got, X couple of weeks to opt out of the scheme, I mean, it's going to create absolute bad will. So I think first and foremost is that communication piece. And until you do that right, I think the public absolutely, and there's going to be reason to be on a back foot with that. On another perspective, so a lot of the work that we do is looking at the value of the NHS data set and how you use this in a commercial setting. So say you've got Google or Apple or whichever company that you're working with, and certainly the NHS itself, I don't think we have the skills, we don't have the money to pay for that, the right skilled people to kind of use the data to the best of its capability and to make sure that we're actually doing justice with this data. At the end of the day, we collect millions and millions of data points across patients, and if we're not using that properly, that's a bit of an ethical conundrum as well. We could have the cure to X disease within that data. We need to work with external counterparts to do this, such as tech companies, pharma, etc. But we need to make sure that the NHS is getting return for that data as well, and making sure that they get fair financial value for the data sets that are being used. And I think this will be a bigger outcry as well. So say that you give away, all of this data at very low cost to X company, they then make billions of dollars or pounds or whatever else on the back of selling their product at the end of the day. Unless we actually take ownership of that properly, I think this is also a huge consideration as well.
Thank you, Saira.
I just wanted to jump in on there. I think the money point is very, very important, and it shouldn't be overlooked. And I think if I was a patient, why am I being cut out of the deal? I would say it's my medical information, it's my data. If I want to interact with that pharmaceutical company or that researcher, then great. What's the going rate for my data, to access it for a day or 1 week or indefinitely? And I think, it's taking the patients along and taking them on that message. And I think it's an uncomfortable conversation. And that's why they're not having the conversation transparently of saying somebody's going to be making money out of this. And I think it'd be a lot better, and you get a lot better research if you had patients engaged in what's being researched at the moment, not researchers doing something with data and the patients aren't involved in it? Why are the patients not involved? Why is there not a dashboard which shows what we did for the patient and what the patient's reported outcomes are at the same time? And I think that the importance here is, how can we trust the data that the patient is sharing, so that the patient is not the outside of this conversation? The patient should be at the forefront of these conversations and should be included, and their consent should be sought. And if they agree to be a data donor, then they should be rewarded for whatever's coming out of that, because we're never going to progress with AI or other such huge data sets if we don't get these people along. And I think the money is a very uncomfortable conversation, and we shouldn't keep sidestepping it, because I can go on the internet now and fill in a survey and I'll get $50, and my medical data is worth a lot more.
I might just jump in there. So it's really interesting you say that at an individual level, whereas I think, when you're kind of using it for research purposes, or you're using it in a kind of bigger setting to kind of build a product, it's the kind of aggregated data that really makes a difference. And having X number, whether it's thousands or hundreds of thousands of data points, to make sure that that tool works. So actually, to be able to individually compensate would then just turn into an absolute nightmare to do that. But the fact that we've got the NHS and to make sure that we've got fair financial return and value for the data that we're giving as collective NHS, that is reinvested back into the NHS to improve health and care services for all, and kind of making sure that that's done in an equitable way as well. So kind of going back to those like fair principles of like why the NHS was found. I think if you're kind of saying to a patient, here's 50 quid for your data, there's market research companies that do that. But also there's groups like Patients Like Me in the US, where you've got, more rare conditions, and people kind of put their health data in to be used in a more, I forgot the word now, to kind of, for people to be able to access that data for more rare conditions. They're then fed back that data on that kind of dashboard setting to say that actually this is, your blood pressure reading should be sat here, or, this is how this should work for you, but also, here's how your data was used in X study, or this is, which pharma company that used your data as well. So I think that's a smaller scale version of showing that how that can be done. But I think to kind of compensate individually, when say you need hundreds of thousands of, potential data points in that to be aggregated.
I think it's hard. I don't know. I'm a skeptic, and I think people have become even more skeptical of the large government projects such as the track and trace, which cost billions, and they used an Excel spreadsheet to track patients, and they lost tracking what the patients were. And I think, the money, yes, it might be difficult, but I think if you want to encourage people to be data donors and to do it for free, then that's fine. But I think it's too much, or it's hard, I think, to ask people to pretend that there aren't going to be huge financial benefits coming out of this kind of research. When you have the kind of COVID vaccine, it's very clear cut. We want to do things in an urgent way. But I think there's lots of research that goes on that makes huge amounts of money, and the patients are just sidestepped when all this money is made. And you can say it will get back to you eventually by better services. But I think I'm quite skeptical, and I haven't seen services improve for a very long time. And I'm saying that as a frontline clinician, as you are as well.
That's certainly an interesting discussion, and I think that ties quite well to one of our next questions. And I think you covered most of it in a way. Do you have a question from Alan that asks, and we covered some of them again, but he asked if records for research are anonymized properly, why would anyone object to them being used? Understand, Abdullah, from what you say, of course, the potential monetization could be a problem. Do you think there are any other concerns from patient side apart from the monetary aspect?
I don't think so. I think if things are anonymized properly, and we talk about the kind of levels of security that need to go hand in hand, and the UK and the NHS is very good at this. I know this firsthand from trying to get on board in terms of different NHS frameworks. The level of security is extremely high. And our company specifically, we work with blockchain technology because we're trying to create a system which is completely trustless, and the level of security is very high there as well. I think there's nothing wrong with it. And again, I don't want to emphasize the point of money. Sure, let's not compensate anybody financially for it, but I think you have to leave that decision with the patient, and you have to say, are you happy to donate this for free? We would like to interact with this data. Same with how we all would like to be organ donors. okay, fine, you can't just take my kidney without asking me. You have to ask me first of all. Some people get paid to donate tissues and whatever it may be for research. And I think you've just got to have that frank conversation. So anonymizing things, no, I don't think it's a big deal. I think if things are anonymized and secure, then by all means, that's the only way we're going to have access to data and to build things on it. But again, I think that's less of a problem for me, because I think the technology is already there to anonymize data, and it's more about just getting patient consent and true patient consent so they understand what's going on.
I guess in a way that goes back to Saira's point about communication and the importance of having clear communication and actually campaigns that prepare these kind of interventions in a way for the future. I'll just move slightly to another direction because we have a question for Arjun. And that goes back to our final question about what did you learn as part of your journey? How did you work as part of your startups? And Dilshan is asking, this is specifically for you, Arjun, how were you able to grow within healthcare despite not necessarily coming from a healthcare background? And I think that's a quite interesting one, because a lot of our participants might not be from healthcare backgrounds, but still be interested in developing their career in this area. Would you like to share your thoughts on this, Arjun?
Yeah, sure. So I think in truth, it probably gives me a different perspective. I think when I was obviously at university, the medics who were studying medicine then went on to perform medicine, whereas now there's definitely a startup culture. There are certainly benefits to being a healthcare, a medic rather than sort of an engineer, and they are probably, clinical safety is probably ingrained, by virtue of your expertise. But I think it's about then surrounding yourself with people who are appropriately skilled in the aspects of the operation that you require assistance in. So although I was a computing sort of student, it wasn't, it was quite obvious, almost as a concept, what we wanted to do: provide the service and then demonstrate that it had some efficacy in terms of impact and engagement. But also because of the fact that this was some time ago, we were also, whether lucky enough is the right or wrong word, I'm not sure, but we were developing as the regulator was developing. So it was actually quite useful, because you had organizations that were really full of people who were clinical trying to speak something technical, and in that respect it was very useful. So working with the digital bodies, etc., has been quite enjoyable, whereas I think now it's actually probably slightly harder, simply because of the fact that these medical organizations now have their own technical teams, and now it can actually get a lot more complex. So I think I was quite lucky because of the fact that regulation was actually being developed as we were creating our own innovations. But I think now there's also like tons of bodies and tons of access to repositories of data and access to knowledge and open source code and all of the bits and pieces you need in order to put together any sort of piece of software or any piece of technology that can help. So I think it actually probably provides a very useful lens or perspective that isn't necessarily shared by medics, and so an engineer's point of view is often quite welcome.
That's a very interesting point, and I wonder, thinking about most entrepreneurship journeys, they don't tend to be a solitary journey. So quite often, the fact that you are not an expert, or let's say you are not a healthcare provider, doesn't mean that you cannot make a useful contribution. And in any other role, you just need to partner with a group of people that can provide different skills, let's say. And I would say even for healthcare providers, when we start a healthcare startup, it's not something that would work only with our perspective as providers. And there's certainly a lot of other roles, as you said, Arjun, from IT perspective, from a marketing perspective, from a communication perspective. So I guess that a lot of the success of a startup and a product actually also relies on the skill set of the team rather than the skill set of the individual. And that's maybe something interesting to reflect on as well. We have another question, which goes back in a way to lessons learned. And it's about lessons learned from something that we have all experienced, which is a pandemic over the last almost 2 years. And we have a question from Sam. And is asking about our experience during the last year if you feel that the public has become more trusting when it comes to using virtual care rather than using face-to-face.
I might go first on that one. I don't know whether trust is trust when it comes to trusting a digital platform. I think it's an interest in terms of the phraseology. I don't think people didn't trust digital platforms necessarily. That was certainly one aspect, but I think people weren't used to using them in the way that they had to use them during COVID. They were almost forced to do that. So trust certainly one aspect, but I think exposure and need wasn't quite necessarily the same. From our own perspective, what we do know is that people, from the research that we've conducted, are less trusting, or more trusting of healthcare apps than they are of things like social media with their data. So there has been a propensity to trust these kinds of digital tools more. But I wonder whether COVID, or at least my perspective is COVID perhaps just forced, the main sort of, segment of society, through this digital technology mangle, and so now everyone is completely aware of how to use digital technology, or majority are aware of how to use digital and are trusting in it because it has provided such a vital service during COVID.
I'd follow on from that. I think again, not so much the trust thing, but certainly people are a lot more comfortable using digital technologies to kind of access healthcare. And certainly it's instead of that kind of softly approach, you were kind of like shoved in the deep end and everyone had to use it whether they liked it or not. And that's coming from a clinical perspective as well, because there's many of my colleagues that hate doing remote consultations. So that kind of goes both ways. But certainly I think even for, patients, a lot of the feedback that we get is, tailoring the right thing for them in future. Oh, can I come and see you next time? But after that, can we do a remote consultation? Because actually it's really easy to like pick up the phone or do a video call. So it's kind of what works for the patient and members of the public at the end of the day, making sure you kind of integrate that into the service model.
I think, just to end on that point, it's the idea if you have good outcomes, if the patient comes to you, you dealt with it using a digital platform or a website or an app, or you use some kind of digital service and the patient had a good outcome, they'll have a great outcome. And if the patient's had a bad outcome, then they'll blame it that we've moved on to this kind of technology. And at the end of the day, we're all operators on one level or another. So it's about how we interact with that information and how we can get the most out of it and the best for our patients. And hopefully going forwards, we're all going to improve our knowledge and our experience and our learnings, and we'll provide a better level of care for our patients doing that.
I was just reflecting on something that Arjun said at the beginning, and I thought it was really interesting that you went back to dissect in a way the word trust, because I wonder if I guess there are several levels of complexity to consider here. I just wanted to share with you very briefly some results of a study that we did asking actually GPs what did they feel about this shift to remote care. And actually, they highlight several things that you said about, of course, the opportunity that COVID represented to hasten the digital transformation. And they mentioned 4 things specifically. One of them was about increasing awareness, as you mentioned very well. Some people were just not aware of it. Some people were increased trust in a way. Some people, because they were forced to use it, trust was improved. And also something really interesting, because they forced us to use it in a way, they increased our digital skills and our comfort using this kind of solutions. I wonder, and for me, actually, that's the big question in a way, is we can, of course, improve trust, we can improve awareness, we can improve ease of use in a way. But the question that eventually remains to be answered is about preference. Even if people trust, are aware, and know how to use it, would it make it want to use it in the future or not? And that goes back to Saira comments about tailoring the offer in a way. This might make sense for some patients, but maybe not for others. And for the same patient might make sense in a context, but not in other. So I guess it was really interesting for me, Arjun, that you went back to dissect the word trust, because I guess there are certainly several levels of complexity within this concept of trust, and it would be really interesting to explore it in further detail. I think we are we don't have more time to answer more questions. We have a few here in the chat, but I'll have to wrap up now. I would just closing the chat. I would just like to thank anyone. We hope that we enjoyed watching. I want to thank our guests for sharing your experiences in such a transparent, engaging, and inspiring way. And thanks for our participants as well for joining us this evening. We'll email you the recording, so look out for that email. We'll send it very soon. And you'll also receive a survey that will appear on the chat box. So please do send us your feedback. That's really important for us to keep improving these type of events and to make them as useful as possible for our participants. So from my side, thank you so much for joining us. We'll see you next time.